All right. Good evening again, everyone. My name is Dr. Kasaga Brian. I'll be moderating today's session, and we are going to start in around 3 minutes. So you're welcome, everyone, to the first SUGES, the Society of Uganda Gastrointestinal and Endoscopic Surgeons. You're welcome to our first continuous medical education event, which is the introduction to liver transplantation, with excellent speakers. So we should be starting in 3 minutes. Thank you. Good evening again, everyone. My name is Dr. Kasaga Brian. I'm a surgery resident at Makerere University of Health Sciences, and pleased to be moderating today's session on Introduction to Liver Transplantation in Uganda by the Society of Uganda Gastrointestinal and Endoscopic Surgeons. So allow me to introduce our excellent keynote speakers today. So our first speaker is Dr. Okello Michael, who is currently the president of Society of Uganda Gastrointestinal and Endoscopic Surgeons. He also chairs as the department chair of surgery at Lubaga Hospital. He is also senior lecturer at Makerere University School of Medicine. He's also a founding member of SUGES, and he also has additional training in hepatobiliary surgery. So he's going to be taking us through the first session, that is Introduction to Liver Transplant. Then we also have another excellent speaker in Dr. Mohammed Sami Abdelwahid. He's a hepatobiliary surgeon from Cairo, Egypt, with a vast experience. He's also very rich in academia with over 10 published papers, especially in the field of hepatobiliary science, laparoscopy, but he also chairs a lot of projects in Egypt concerning liver transplant. So in this, he's also going to be talking about how to start a liver transplant program, and he's going to be sharing his experience from Egypt. Yes, thank you so much for everyone for logging in today, and allow me to invite the first speaker, who is the president of SUGES, Society of Uganda Gastrointestinal and Endoscopic Surgeons, to lead us ahead in the session. Thank you.
Thank you very much, Brian. And I welcome you all to, this is our first CME for this year, 2024. So I welcome all of you. I will be talking about introduction to liver transplantation. I will basically be going through the science, and want to try to make it as simple as possible. And we understand some basics as that pertains to liver transplantation. So my outline is I'll go through the definitions, some of the common definitions when we talk about liver transplantation. And then I'll go through the history of transplantation in general, and then the etiology of liver disease and indications for liver transplant. And then we'll also look at the contraindications. And then there are some prognostic scores we use in liver transplant. And then we'll see where we stand and the way forward. And we'll conclude. So I'll start with liver transplant. It's a surgery basically to replace a diseased liver with a healthy liver from another person. The whole liver may be transplanted or just part of it. So in diseased donor liver transplant, also called cadaveric liver transplant, donated liver is retrieved from either a brain-dead donor or a circulatory, also previously called cardiac dead donor. And there is a general definition worldwide accepted for death, because especially when you talk about diseased donor liver transplant, there are controversies about death. So the Uniform Determination of Death Act that was promulgated in 1981 There is an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including brainstem, is dead. And the determination of death must be made in accordance with accepted medical standards. And this was derived from the Harvard School Committee resolution of 1968. So most of the definitions around brain death amongst all the centers that do transplant revolve around this. There are a few differences here and there, but all of them are derived from the Harvard School of Medicine Committee resolution of 1963. And the original committee decision even included EEG. It's a flat EEG, but that was dropped with the time. And there are other modifications depending on what literature you go through. But in relation to Uganda, where the president signed the transplant bill into law, and the first 5 years, we're supposed to be doing living donor liver transplant. Then after 5 years, we can start talking about disease donor transplant. But we can start the discussion now. And since I'm going to be talking about the indications and the contraindications, generally for liver transplant, they are the same. So because of the controversy surrounding definition of brain death and saturated death and the community acceptance, the Uganda Human Organ Donation and Transplant Bill 2021, which was signed into law just last year around May, only allows living donation for the first 5 years. Then thereafter, disease donation can start. So there's a split liver transplantation, which is a subset of disease donor liver transplantation. And this came in because the number of donors are less than the number of recipients. So there's demand. The demand is more than the availability of the donors, or donated livers. So split liver transplantation was introduced by H. Meyer in 1988. And initial results were not encouraging due to poor quality of grafts, and most of the recipients needed retransplantation. But as the technique kept being refined, the outcomes improved. So initially, they would give an extended right to an adult and then the left lateral segment to a child or a pediatric. And as we look at the principles later, the quantity and the quality of the liver matter when you're doing transplantation in terms of outcome. So in split liver transplant, you can do adult and feed, or other people stretch, you do an adult and another small adult. And what you're basically trying to play with is to make sure that you have adequate liver for both recipients. So when we look at this picture, there's the black aspect. If we follow the black line, you will end up with, you will go through what they call the Cantonese line. That separates the functional right liver from the functional left liver. So if the split occurs along the black line, then you will end up giving the bigger lobe to an adult, and then the left functional lobe to maybe a smaller adult. And then if you follow the yellow line, you do an extended right hepatectomy. So segment 4 also goes to the right. So this is a little bigger. So still, this is the original technique of split liver transplant. So this extended right hepatectomy would go to an adult, then the left lateral segment, which is small, would go to a child or a pediatric age. And this is basically trying to make sure that the recipients get an adequate liver volume that will meet their metabolic needs post-operatively. This is basically to give you an idea about split liver transplant. So when you split your liver, you can split in situ or ex vivo. When you split basically, liver transplant is about anastomosis vessels and a few tubular structures. So if you split the left lateral segment and you're giving to a pediatric, you'd have to reconstruct. So you have to reconstruct the outflow and then the inflow. The inflow basically have the portal triad, which has the hepatic artery, the bile duct, and the portal vein. So depending on how you split your recipient, you would have to reconstruct the inflow portal vein to portal vein. Usually the bile duct goes to the jejunal limb, very particular jejunal, and then artery to artery. That is the inflow reconstruction. Then the outflow, basically the hepatic vein, it is the left lateral segment, have the left hepatic vein being reconstructed back to the IVC. Then looking at the right, this picture is actually not a classical right hepatectomy. This looks like a right posterior segment, but still you reconstruct the inflow and then the outflow. And if this is a right posterior segment, then this one will be the right hepatic vein back to the IVC. Then the inflow still have the portal triad, which has the three structures. The portal vein to portal vein, hepatic artery to hepatic artery, and then the bile duct to jejunal limb, very particular jejunal stomach, to restore your inflow. And then after that, split liver transplant was trying to solve the issue of fewer livers being available compared to the need, the recipient's need. So split liver transplant that started in 1988 gave rise to living donor liver transplant. And this is because in countries where the laws permit disease donor donation or cadaveric transplant, the patients have to be in a waiting list. And the most sick patients determined by the prognostic score, you can look at them, the MELD, which determines the 3-month mortality. The higher your MELD, the higher your chances of dying within 3 months. And then the Child-Pugh score, which determines the severity of your illness, classified as ABC, depending on the degree. So the MELD score is used in disease donor to classify the severity of the illness, and depending on how high your MELD score, the higher your MELD score, the higher is your name will be on the wait list for disease donor for those countries that allow disease donation. So most people would die before they get the organ. So this introduction of living donor liver transplant in the early 1990s was to try to mitigate this wait list mortality. So living donor liver transplant involves removal of a portion of the living donor's healthy liver for transplantation into a recipient in need. And in most centers do right lobe donation, and it's a common one. And this is basically for adequate graft recipient weight ratio, which is because if you take a smaller portion and you transplant to a very sick recipient, there's a possibility of worst case scenario, the liver fails to work post-operative, what we call primary non-function. Or you end up with early graft dysfunction. And then if the lobe is too small, you can also end up with what they call small for size syndrome, which will manifest later with the same graft dysfunction and has a high morbidity and mortality. So the center where I came from in India, I would mostly use the right lobe, but you leave the middle hepatic vein with the donor, and then you have to reconstruct the middle hepatic vein using an artificial graft, polytetrafluoroethylene. But there are centers that are practicing left lobe donation as an option, and it is possible, and we'll look at it later. So if you're doing your right lobe donation, because you don't want to compromise the venous outflow of the donor, usually you leave the donor with the middle lobe, because the middle hepatic vein, because the middle hepatic vein drains both the right and the left livers. So if you don't leave the donor with adequate outflow, then that segment becomes congested and the future liver remnant is compromised, and that can lead to donor mortality. And donor safety in living donor liver transplant is key. You cannot compromise donor safety. So when you're doing right lobe donation, the middle hepatic vein stays with the donor, then you reconstruct. This is segment 5 vein and segment 8 vein. You reconstruct with an artificial graft, and then you reconnect. Then, of course, the right hepatic vein will be there to be reconnected back to the IVC. Then the inflow as before, as we have seen earlier. Now, there is CT volumetry is a very important investigation when you talk about living donor liver transplant. And it is important for the safety of the donor and the safety of the recipient. First of all, the donor should, the liver that is what we call the future liver remnant, what remains with the donor, should be adequate enough to sustain the donor requirements postoperatively, while also balancing what the recipient is getting should be enough to maintain the metabolic needs of the recipient. And there are calculations that we use. GRWR is graft recipient weight ratio. So it is done pre-operatively during CT volumetric assessment. You basically do a virtual hepatectomy. You do a CT dynamic study of the liver, and during that, you see this is the vasculature of the outflow. The right hepatic vein, this is the middle hepatic vein, then the left hepatic vein. So the outflow has 3 veins, and this affects the outflow because the middle hepatic vein, which is in the center, drains both the left and the right. So when you're doing a right hepatectomy, you have to take that into consideration. When you're doing a left hepatectomy, you have to take that because the NHB is in the middle. So when you do a virtual hepatectomy, you plan pre-operatively, and you're able to calculate the amount of the liver that goes to the recipient and how much that remains with the donor. And based on those calculations, you're able to tell that whether it's adequate or not. And your graft recipient weight ratio will be able to tell you how safe the operation is pre-operatively. But the challenge is the pre-operative assessment may not exactly translate into the intraoperative findings. We've had situations where preoperatively, the minimum recommended graft recipient weight ratio is 0.8. So if you go below 0.8, then it starts increasing the risk of getting small for size syndrome for the recipient. But there are cases where you calculate your graft recipient weight ratios in CT volumetry. Preoperatively, you get maybe 0.9. Then intraoperatively, after you've done your donor hepatectomy, after donor hepatectomy, you weigh the liver, then you flush it and put it into the preservative solution. So after weighing, you recalculate the actual graft recipient weight ratio. And intraoperatively, you can be shocked that what operatively was 0.9 now becomes 0.6 or 0.7. And you know there, you've already operated, you've already taken out the liver, so the transplant has to continue. But now you start planning to prevent the small for size syndrome. And one of the mechanisms that intraoperatively, if you anticipate that the graft is small, there are some graft inflow modulation techniques you can employ intraoperatively to try to prevent the small for size syndrome postoperatively. And we'll look at them later. So the planning starts preoperatively, and then intraoperatively, the decisions have to be made. Otherwise, you don't wait postoperatively and you go into panic. And virtual CT volumetry is very key in living donor liver transplant. And if you're to start, this is one of the things that we have to take into consideration. So just some pictures. As we had said earlier, the middle-hepatic vein, which drains both the left and right livers, if you follow the functional left and right cantilus line, the middle-hepatic vein has to remain with the donor, the safety of the donor. And then you reconstruct to be able to drain segment 8 and segment 5 well, you reconstruct the MHV using a graft, an artificial graft, usually polytetrafluoroethylene grafts are available. And during your fetal volumetry, you also measure the diameters of those veins so that you plan the diameter of the graft you're going to use. And then you reconnect them, and then now finally connect it to the IVCs to complete the outflow. When you don't do this, then you get congestion of segments 5 and 8, and then you have graft loss, and still this process can push you towards post-operative graft dysfunction, and you may progress into losing the patient or requiring a retransplantation. So graft weight recipient weight ratio, also called GRWR, which we had mentioned, this is its formula. You have the graft weight of volume in grams, or the volume is within mils over the recipient weight times 10. So basically, the taller or obese individuals require a bigger size of liver, vice versa. So based on this, you cannot get someone who is tall and they are 90 kilograms, and you get a donor who is 40 kilograms and you think it will work. It will not. Because if you're small and you're 40 kilograms, also your liver will be smaller. So most likely, as even you plan, you work out your recipient and donor. If you have a recipient who is 60 kgs, most likely you get a donor who is around 60 or 62 for you not to run into problems even during the evaluation. And this starts, so you start from clinical, then now you go into your CT volumetry, and then you go into a op where you plan to avoid a small for size syndrome as we have discussed. And so, as we had mentioned earlier, the graft recipient weight ratio should not be less than 0.8 for you to avoid that small for size syndrome. And that can lead to graft dysfunction with a high morbidity and mortality. And this is very important in a living donor liver transplant, but it's also important in split liver transplant, as we have seen earlier. That's why you decide the smaller part. If you're doing an extended right, then the smaller part should go to a child because the child has a smaller weight. So most likely when you calculate the graft recipient weight ratio, it should still be above 0.8. So there are different definitions for small for size syndrome, depending on the different, but just to summarize is different criteria depending on different publishers, but the key aspect is you have to have that point to liver dysfunction is the usual signs. You have a hyperbilirubinemia, you may have a sign of decompensation, which is ascites, and some you may have hepatic encephalopathy, which are all signs of liver decompensation. And that shows you that whatever you've transplanted is not working. If your liver is beginning to decompensate, the immediate post-op. So different groups have different definitions, but those are the key aspects. You have an aspect of hyperbilirubinemia, ascites, hepatic encephalopathy, or coagulopathy, which you may have which is an INR above 1.6, 1.5. And so depending on the different groups, we have those definitions. So small for size syndrome causes are usually multifactorial. It's not just the graft recipient weight ratio being less than 0.8, but there are recipient factors. If the recipient has sarcopenia, is very cachexic, or has the pre-op portal hypertension, which is more than 20 milliliters of mercury, or we have a graft, the issue of graft quantity and quality. So graft quantity, you can determine this preoperatively during your CT volumetry. Then the quality is when you're choosing your donor. They shouldn't have anything that compromises the quality of the graft. Someone who is obese will basically have hepatic steatosis, and someone also who is who has any form of any liver disease that can compromise graft quality. Hepatitis has been taking alcohol should be avoided as a donor. Then better surgical techniques to minimize hepatic artery or bile duct stenosis, also prevent hepatic artery thrombosis. All these are important to prevent small foci syndrome. And then a young donor, preferably 45 years or less. Then use of graft inflow modulation also is very important in preventing this small foci syndrome, as we'll look at later. So factors contributing to small foci syndrome, we've seen graft size. The graft temperature should not be less than 28. Then the graft volume to standard liver volume ratio should be between 30 to 40%. So preferably. Then when you look at the recipient factors, the degree of preoperative portal hypertension plays a part, and then poor nutrition, as we have mentioned earlier. Surgical techniques, if you get outflow obstruction, either because of poor reconstruction when you're reconstructing, when you're connecting your hepatic veins back to the AVC, or anastomotic stenosis of the hepatic artery or bile duct, hepatic artery thrombosis. Those are all issues. And then donor age. If you have a donor more than 45 years, it's also a problem. Graft quality is also an issue. And then these factors can lead to excessive portal vein flow or portal vein pressure. And then to solve them, you need to do graft inflow modulation techniques. And some of them include splenic artery ligation, splenectomy, but these ones have their issues. The one I've seen most practiced is the hemiportocaval shunt, which has good outcomes. Portal vein ligation, you can end up with splenic abscess formation. And splenectomy, you can end up with portal vein thrombosis. So hemiportocaval shunt is the one that has shown, but there are also pharmacological approaches where you can use low-dose somatostatins and the rest to prevent small foci syndrome. So basically, if you're to prevent the small foci syndrome, in case you're using, it's better use the right graft because it's bigger than the left graft. But if you're using the left liver graft, then and your GRW is less than 0.6, then most likely you'll have to do graft inflow modulation. And the most preferred for graft inflow modulation, especially if the portal vein pressures are more than 20 meters of mercury, is a hemiportocaval shunt. You basically connect the portal vein to the inferior vena cava. So because high portal flow pressures are dangerous for that new liver. And when it is already small, it's even worse. So controllable factors affecting quality of transplanted liver intraoperatively are also what we call the ischemia time. And ischemia time is divided into warm ischemia time and cold ischemia time. The longer the ischemia time, this will affect the quality of your graft. Now, there are people who think you can just kill someone, especially the issues of deceased donor transplant. Kill someone, get their liver, and fly it to another country 24 hours down the road. That is not possible because the quality of your liver is affected by the ischemic time. The shorter it is, the better the quality of the liver. Now, warm ischemia time is defined as ischemia during implantation. So when you remove the liver from the donor, you transfer it to the cold perfusion if it's living donor, so that you can reconstruct your middle hepatic vein in the cold perfusion during the benching. And during all that time, your liver is disconnected from its original vascular supply. So what is preserving it is the cold solution, preservation solution, but also that temperature contributes, lowers the metabolic damage. It lowers the metabolic damage to that liver. So warm ischemia time is defined as ischemia during implantation from removal of the organ from ice until it is reperfused. And ischemia during organ retrieval from the time of cross-clamping or assistor in non-heart-beating donors until cold perfusion is commenced. So the warm part is before you put into the cold solution or your perfusion solution. And it is longer for disease donation after circulatory death because for circulatory death, there's a standard requirement. You have to observe, disconnect. If the patient is in ICU intubated, you have to disconnect and then watch them for 5 minutes. And then when you go to theater, by the time you harvest, the heart has stopped pumping, and all that is counted as ischemia time. As opposed to disease, the donation after brain death. Donation after brain death, your brain dead, but the heart is still beating. So if the patient is intubated, is in ICU, the heart is still beating, so the organ is still vascularized. So the ischemia time for brain death donation is shorter than that for circulatory death donation by virtue of the fact of that. While the one for living donor donation should be the shortest because you have control. You operate the donor and the recipient on adjacent theater rooms, and you determine when to clamp. When after you coordinate, two teams coordinate. So once you're ready to explant, to remove the diseased liver, then this side you can be able to take out the donor liver so that you shorten the ischemic time. So when you have long warm ischemia time and cold ischemia time, this causes ischemia reperfusion injury in the post-transplant and hence poor graft function and overall outcomes. And some of the strategies are those, like you have to try to shorten the cold ischemia time and warm ischemia time. And for disease donation, which we are not going to start with, but it's good to think long term because 5 years from now, in case it starts, we shouldn't be starting from zero. So the discussion can start now. There is now normothermic machine perfusion, which is used especially for donation after circulatory death, where you connect the donated organ into a machine, then the machine perfuses it, you get oxygen, nutrients, and can even test the functionality of the organ before you transplant it onto the individual. You can even test, you see your liver forming bile, you can even take off samples and do LFTs and the rest. And you test the quality and the functionality of that liver while it's in this machine before you transplant it onto a recipient. So there's a different tolerance. The tolerance for different organs to cold storage or in cadaveric transplant is important, especially for disease donation when you're doing multi-organ procurement. When you're doing multi-organ procurement, the rationale is followed. For example, for countries where you have capacities to do heart transplant, lung transplant, liver transplant, pancreatic transplant, kidney transplant, if one donor can save almost 5 patients plus. So because the requirements, the heart, ideally after 1 hour, the extra hours you take beyond 1 hour affects survival. So the heart, if you're doing multi-organ procurement, the heart is the first to be harvested because of its short tolerance to fall ischemia. And then followed by the lungs, 6 to 8 hours, then liver, then pancreas, then kidneys. So in multi-organ procurement, so the chest team starts, heart first, lungs, then the abdomen, the liver team goes, then it's the kidney which is most resilient and can take up to 18 hours. And some literature can even stretches it up to 24 hours. Then we have different solutions we use for organ preservation. These are the solutions that preserve your organ. And the common ones are Universal Wisconsin solution, the UW solution, and then the HTK solution. HTK is histidine tryptophan ketoglutarate solution. And this is basically the composition of these different solutions. You have electrolytes, you have osmotic agents and colloids, and then you have pharmacological agents to try to preserve your organ at that stage where it is not connected to any blood supply before you implant it onto the recipient. And then we are talking about normothermic perfusion, and the commonest organ, the machine is the organoid. And these are the machine looks like this, and very important for disease donor donation, where the quality of liver is poor. You can test its functionality before you transfer to a recipient. And this also prolongs, it is not as bad as it solves the problem of cold ischemic time. If you compare normothermic perfusion versus standard cold ischemia, this is better. Now, this slide is crowded, but I just wanted to share with us the journey to liver transplantation. People have struggled. For us, right now in India, the center where I was, they're doing an average of about 15, 20 transplants per month. But if you look at the journey of transplantation, the journey, the people who started transplantation suffered. But the hallmark of transplantation, the outcomes improving, was basically the key aspects was one, the development of an improvement of skins, especially in vascular surgery. As we had seen, basically anastomotic vessels and articular structures, but also introduction of immunosuppression, because initially rejection was a big problem. And then ultimately the introduction of living donor liver transplant. So for the purposes of liver, the father of liver transplant, Thomas Stezo, first did a liver transplant in 1963, but the outcomes were not good. So the successful transplant was actually in 1967 in Pittsburgh. This is when we had a successful liver transplant with a long-term survival, 1-year survival. Otherwise, the initial journey, people tried transplanting, even kidneys from chimpanzees to humans. There was no long-term survival. But we started documenting long-term survival from 1960s. But still, there were challenges with good immunosuppression until there was introduction of tacrolimus. And once tacrolimus came in, now we have very good outcomes in terms of long-term survival. There's a common story of Professor Rila Mohammed, who transplanted the youngest child at 3.5 kilograms. And the child grew up to become a lawyer, and they are now over 23 years. And that case is recorded in the Guinness Book of Records. And that is to demonstrate long-term survival for liver transplant. So things have improved now, but when you look at the journey, the people started, it was a big hassle. And since there's a claim that the world is a global village, We are, as a country who have not started, we are 60, 70 years late. But I don't think we should continue watching the world progress and we do not start anything. Indications of liver transplant, one of them is acute liver failure. There are multiple causes of acute failure, and this is common in the pediatric age group. And one of them is this common painkiller, Panadol, acetaminophen. You poorly store Panadol in the house, the child gets a whole tin of Panadol and swallows, and they go into acute liver failure. But there are other causes for acute liver failure, viral, hepatitis B, CE, and many other causes. And there is a criteria for prognosticating acute liver failure. And these patients come in sometimes hepatic coma with the coagulopathy, INRs above 6.5. And what can save them is an emergency transplant. But there are documented cases where some, now especially nowadays in the setting of advanced ICU care, there are some cases where some patients have recovered from acute liver failure without transplant, called transplant-free recovery. And then chronic liver diseases with liver decompensation. Any chronic liver disease that gives you end-stage liver disease or liver cirrhosis is an indication. And when you have liver cirrhosis with decompensation, that is an indication for liver transplant. And the degree of decompensation as calculated by the males will depend. If it is cadaveric program, we put you on a higher list for transplant. If you have your living donors, and then you can plan your transplant. Then we have malignancies. Now, indications for liver transplant are changing. What initially were contraindications as medicine improves are changing into indications. So hepatocellular carcinoma, since we are surgeons, I'll emphasize on this one a little later. But now, cholangiocarcinoma was previously a contraindication, but from the introduction of the Mayo Protocol, which is a strict protocol where you have neoadjuvant chemo, patients are highly selected, this became an indication. And nowadays, they are pushing boundaries also. Colorectal liver metastasis is an indication for liver transplant. Then you have other metabolic conditions, non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and all these ones basically lead to chronic liver disease with decompensation. And then Crigler-Najjar disease, hemochromatosis. Hemochromatosis is an indication that leads to liver cirrhosis and decompensation. Otherwise, nowadays, there are medical interventions, hypocreative phlebotomy, especially when it is diagnosed early, before it causes liver damage. There are medical interventions. Wilson's disease, basically excessive copper deposition in multiple organs, and liver, eye, brain, and other organs. And all these conditions also lead to chronic liver disease, and ultimately the liver decompensates. Then we have cholestatic diseases, biliary atresia in the pediatric age group. If initially you can sort it out with a Kasai procedure, then you buy time. But ultimately, even after Kasai, those patients still need a liver transplant later. Then you have primary sclerosing cholangitis, primary biliary cirrhosis. Then there are others, hepatopulmonary syndrome, familial amyloidotic polyneuropathy, hepatorenal syndrome, hepatopulmonary hypertension. Hepatic hydrothorax, you not find it listed, commonly has an indication. But when you have liver cirrhosis with decompensation and also have hepatic hydrothorax, then you basically need a transplant. So starting with acute liver failure is defined as acute development of jaundice, synthetic failure, and hepatic encephalopathy in patients without a previous history of liver disease. And there are different definitions. The time span is about 12 weeks. And you have different spectrum. Initial, it's hyperacute, then acute, then can become subacute, depending on which author you're considering. Then you can have fulminant and subfulminant, and all depending on the duration. But for acute liver failure, I think most centers consider the King's College criteria for prognostication. And when you look at the etiology of acute liver failure, commonest is panado intoxication, but we have viruses B and C, and then the rare ones, E virus, also cytomegalovirus, Epstein-Barr virus, herpes simplex virus, varicella zoster virus, then autoimmune hepatitis, Wilson's disease, Budd-Chiari syndrome, and then generally other drugs. You can have drug-induced liver injury, really. And then we have acute fatty liver of pregnancy. Then you have HELP syndrome can worsen and you go into liver failure. And you can have ischemic hepatitis, either due to clots or anything. Then there are sometimes when you just don't fail to get the cause. It's that indeterminate. And sometimes this ones with indeterminate cause even have a worse prognosis. So King's College criteria for prognosis of liver transplantation is we have divided into acetaminophen-induced acute liver failure and non-acetaminophen-induced acute liver failure. I know the people in attendance are in different cadres. Acetaminophen is basically like Panadol. So when you do your ABGs, arterial blood gases, and the pH is less than 7.3 after fluid resuscitation in a child with acute liver failure, you know that's a poor prognostic sign. And then you can just have that alone or all of the following: prothrombin time more than 100 seconds, serum creatinine more than 3.4 milligrams per deciliter, or grade 3 to 4 hepatic encephalopathy. Then for the non-acetaminophen-induced acute liver failure, the other causes we've seen, hepatitis and the rest, either you have a prothrombin time more than 100 seconds or an INR more than 6.5, or three of any of these factors, non-A, non-B viral hepatitis or drug-induced or indeterminate etiology. Then time from jaundice to hepatic encephalopathy, more than 7 days. And then the age, less than 10 years or more than 40 years. Then prothrombin type, then serum bilirubin. And then there's a subset where you, instead of, it's between, you have acute and chronic liver failure. And this one has different definitions. We have the Asia Pacific Association for the Study of Liver definitions, and then the European Association for the Study of Liver definition. There are variations, but so in terms of, so for the Asia Pacific, that is India and the rest, it is the presence of an acute hepatic insult, which manifests as jaundice with coagulopathy, that's INR above 1.5, and gets complicated within 4 weeks by ascites, encephalopathy in a patient with previously known or unknown chronic liver disease. And the mortality within 4 weeks is high. And if you compare it with the European Association for the Study of Liver, it's development of an acute deterioration of pre-existing chronic liver disease, usually due to a precipitating event and leading to a high 4-week mortality due to multisystem organ failure. So in terms of duration, this one's Asia says 4 weeks, the other is up to 12 weeks. And you have only hepatic insults like alcohol, hepatitis, viruses, drug-induced liver injury, autoimmune hepatitis. While this way, in the European Association of Study of Liver, you have both hepatic and extrahepatic insults like infection and sepsis. So these differences you have to take into consideration when you're defining SCLF. So chronic liver disease as an indication for liver transplant, the hallmark basically cirrhosis, which is your end-stage liver disease. And different causes, viral, non-viral, alcohol, metabolic, and the rest. So when you reach cirrhosis, cirrhosis is your end stage and is considered irreversible. Though nowadays there's data showing that you can have recompensation, cirrhotic recompensation, and still understand. They will look at a little. So when you look at cirrhosis, the key prognostic factors are you have portal hypertension, then synthetic dysfunction. Usually, if you do your labs, albumin will be going down, but also you have risk of development of hepatocellular carcinoma. And liver transplant for hepatocellular carcinoma in the cirrhotic liver sorts out both conditions. You're treating a cirrhosis, which is end-stage liver disease, but you're also treating the cancer. So this portal hypertension will lead, all these cirrhosis can be compensated or decompensated. When it decompensates, then you end up with the features of decompensation: hepatic encephalopathy, upper GI bleeding from esophageal varices, ascites. And when you have an acute and chronic picture, you also have coagulopathy and the rest. And so when you have your chronic liver disease progressing from compensated to decompensated disease and development of hepatocellular carcinoma, there may be aspect of reversal based on current treatment. And when you summarize all the different causes that will give you liver cirrhosis, you have your viral factors, fatty liver factors, drugs, storage diseases, bad Chiari syndrome, and other bacterial cholangitis like you have in PSC and primer and the rest. So the concept of liver recompensation was developed during the Baveno two conceptors. It introduces the new concept of hepatic recompensation, which refers to the reversal of structural and functional changes of cirrhosis after removal or cure or suppression of the etiology of cirrhosis. So it is like hepatitis C. When you achieve complete viral suppression, there is a small section of patients that may have liver recompensation. But these are still new concepts that are under study. So when you look at the criteria for liver recompensation, so you have etiological cure. So if it is alcohol-induced liver cirrhosis or hepatitis C-induced cirrhosis, that etiology has to be cured. Then the resolution of any signs of decompensation, ascites, hepatic encephalopathy, then no bleeding events due to esophageal varices for more than 12 months, then improvement in liver function. And up to now, there are still unanswered questions in terms of etiological cure for non-alcoholic related causes like NASH and the rest. And then there are still a lot of areas for unanswered questions as we discuss hepatic recompensation. But these are important aspects to take note of, and the references are there. So looking at our prognostic scores, CTP looks at long-term, at least 1 year mortality, as versus MELD, which looks at the 3-month mortality. So you have classes A, B, C, and the points are between 5 and 15. So 5 to 6 is A, B is 7 to 9, C is 10 to 15. And when you look at 1 year mortality for the different classes, for A, we are good. But for C, as you go, the survival is, this is 1 year survival. The survival gets worse. Now, model for end-stage liver disease MELD basically uses lab parameters, total bilirubin, INR, creatinine, and there are apps on the phone, you just put in those apps and they give you a calculation. And this was actually initially introduced by interventional radiologists to evaluate mortality after TIPS, transhepatic procedure to sort out portal hypertension. So when you look at the 3 months survival, so the higher your MEL, so the minimum score is 6 and the maximum is 40. So the lower your MEL, between 0 to 10, your survival, your 3 months survival is very high, approaching 100%. But as you approach 40, your survival is less than 20%. That's why priority goes to those patients with a high MELD score, because they are trying to solve them. And this MELD score was introduced in 2002. But along the way, there are modifications. Now there's sodium MELD. There's also tumor MELD for HCC and other factors for disease donation that need exception. So hyponatremia is a negative prognostic factor associated with increased mortality. And hyponatremia predicts hepatorenal syndrome, which in itself increases mortality. So looking at this graph, the relative risk of death, looking at the serum sodium. So if you look at between 125 and 140, this is the lowest relative risk of death. The chances of dying are lower at around here. But mortality increased by 5% for each millimole decrease in serum sodium between 125. So as you decrease, the risk of death increases, and then it stabilizes around below 125. But the limitations here are for the sodium MEL, the use of diuretics, and then intravenous fluids. And then HCC has an indication. The key thing here is liver transplant will cure both the liver cirrhosis, which led to HCC, and then the cancer itself. And looking at the BCLC, this was the latest BCLC 2022. The previous one, intermediate stage, you couldn't qualify for transplant, but now at least intermediate stage also qualifies for liver transplant. And your survival is expected to be more than 5 years to get transplantation for HCC. And there are different factors, patient factors, and the different tumor characteristics that you consider. I'm running out of time. And then still for HCC, the metro ticket, which combines the alpha fetoprotein and the number of tumor nodules summed up in size. So the bigger your HCC and the higher your alpha fetoprotein, the worse your 5-year survival. So when you're picking a patient for transplantation for HCC or even for resection, you don't want to go for the bigger tumors, and you don't want to work on patients with alpha fetoprotein more than 1,000, because 5-year survival is almost less than 20. If you have alpha fetoprotein over 1,000 and a tumor size of about 10 centimeters. So you'd want, if the tumor is big, you'd want a lower alpha fetoprotein to have a good outcome. And this is basically the metro ticket 2.0. Pediatric indications of transplant. Number one, the top on the list is usually biliary atresia. Either after failure of the Kasai procedure or before Kasai and the child is decompensating. The child presents before Kasai and has ascites, hepatic encephalopathy, jaundice. It's straight liver transplant. Inborn errors of many of them are the second important indication. And then contraindications are also evolving, and the patient might be too sick to to undergo. A transplant is a major procedure, most times about 10 hours. So if you have severe cardiac or pulmonary disease, might be a contraindication. And then for those for alcoholic liver cirrhosis, they need, most guidelines need abstinence for at least 6 months. So if the patient is alcoholic and is still actively taking alcohol, that might be a contraindication. HCC with extrahepatic disease is a contraindication. Also, concurrent extrahepatic malignancies is a contraindication, but eventually reevaluated after successful treatment. If you have liver disease with another extrahepatic malignancy, then sepsis, because postoperative will be on immunosuppression. So if you have active sepsis and then you get a transplant with immunosuppression, it worsens. Then relative contraindication. Remember, we said cholangiocarcinoma is an indication, but previously it was also contraindication. Alcohol abuse, and then hepatic metastatic endocrine tumors. Morbid obesity is a relative indication because nowadays you can do a dual lobe transplant where you have 2 donors giving 1 recipient. But persistent non-adherence, if you have someone with psychiatric issues and you know they will not be adherent to immunosuppression, that's a contraindication because the biggest cause of rejection is non-compliance. So someone with psychiatric issues who will not be adherent to drug therapy is a relative contraindication. I need to finish up. So as a country, we have some positive steps. At least open liver resections and complex hepatopancreatic blood surgeries are being done routinely in Uganda, in Mulago, Rubaga, and other centers. We are also starting to do laparoscopic liver surgery. So if you're able to do complex HPV surgery, then most likely you're comfortable with donor hepatectomy, almost. And then our national referral started training intervention radiology, and we need more of this. And I hope the scope increases. And then recently, good news, started kidney transplant. So as kidney transplant takes shape, we should be warming up to progress into liver transplant. And then we have a law in place, and that should be okay. And the centers, we have centers that have invested in transplant infrastructure and equipment. And those centers, we shouldn't let them go into waste. A worst case scenario, you'd rather have experts from India or Cairo flying in to do transplants here as opposed to relying on patients going out all the time. Sometimes they are too sick to travel these long journeys. So Rubaga has a transplant theater, Mulago has a transplant theater, and they are all awaiting accreditation from Ministry of Health. And the Rubaga theater was commissioned by the Director General in August last year, but it's awaiting accreditation. So way forward, we are utilizing the National Society, the Society of Uganda Gastrointestinal and Endoscopic Surgeons to bring VIA and HUD experts together. And we are ensuring that already established transplant infrastructure and equipment investments in Mulago and Rubaga do not go to waste. But by preparing ourselves, and it doesn't matter if it take 1 year, 2 years, but for us, we shall do our part. The institutions will do their part, the government will do its part. But as the experts, we shall do our part. And utilize the existing international collaborations. We have friends in Cairo doing transplants. We have friends in India, South Africa, and all these are opportunities. They can come and work with us to develop this. I would like to end there. Thank you.
Yeah, thank you so much, Dr. Okello, for that wonderful session. And thank you for summarizing that by saying that as Uganda, after performing the first liver transplant, we should be able to perform the first liver transplant. Sorry, that was the kidney transplant. We should be able to have the first liver transplant within 2 years. And as Society of Uganda Gastrointestinal and Endoscopic Surgeons, we hope to achieve this within the coming 2 years. Yeah, thank you so much for that. And before Maybe we shall get questions at the end, but allow me to invite our visiting expert from Egypt. I'll kindly request you, Dr. Okello Michael, to invite him such that he can also share his experience from the liver transplantation program in Egypt. Thank you.
Thank you very much, Brian. Dr. Sami, are you ready?
Yes, Dr. Okello, I'm ready.
Please go ahead and share your presentation. I'm sorry for taking long.
No problem at all.
All right.
First of all, I would like to thank Professor Okello for this nice opportunity and his kind invitation for me to be with you in this very elected lecture about liver transplantation. I'll try to share my experience, maybe.
Yes, 5 minutes.
Okay, start from here, okay? So, my last lesson I would say about it, to keep your contact with your foreign mentors, because until now the French team and the Japanese team, we have very contact with them in Egypt, and they come in some difficult cases, and they some upon request from some patients who wants to be done by the foreign team. So I myself contact my mentor weekly by email basis. I send him emails every week to ask him about anything regarding my cases we have done here. And I keep updated with him for any new techniques or any new things that you have done, they have invented or they are trying in their center, okay? Please again. Next, please. This is just, I thought that Professor Kasara was here in Egypt last year with me to perform a case for pediatric liver transplant. So keeping in contact with your foreign mentor is very, very important, because I called him about this case and he came to Egypt to make it. Okay, so this is very important to keep your contact with your foreign mentor. Okay, next, please. My personal experience I will share now in two centers that initiating. One of them is my national center, National Pathology Center. We started in 2013, and we have done 160 cases until now. Okay, next, please. And the other one is the Cairo Fatimic Hospital. We started in 2018. This is my new center, and I work in the both centers until now, and we have done 216 cases until now. From them, 18 are pediatric. Next, please. This is the NCCHD in Japan. I stayed 1 year with them, and I attended 58 cases for pediatric liver transplant. And also I worked in Dar Fouad Hospital. He is a private hospital in Egypt for 1.5 years, and I participate in 61 cases with them. Next, please. This is some photos for the young children that were operated by me and my team, and they are successful now, and they are living very nice now. Just to encourage you. Next, please. This is the next, please. Next. This is the indication. This is mostly the indication in Egypt. Mostly indication was HCV and HBV and HCC. This was the main indication, the hepatitis virus and the HCC in Egypt. But nowadays, maybe the HCC has come back. Is not the first indication like it was before, because after the treatment of Egyptian people with the mass treatment for the antiviral drugs, and also this some indication for the pediatric group also. This is my experience or my the cases we have done. Okay, next, please. This is the cost in Egypt now for the foreigners, mostly in public hospitals about $13,000 US, and in private hospital it costs about $20,000 US. Just to make let you know this. Yeah. Next, please. My conclusion is a bad start costs a lot, as I told before, but never preclude your progress because of this bad start. And start as soon as possible. You have the political will and the financial support and suitable hospital with the infrastructure and young motivated team. Resist your dreams, resist any obstacles, and maintain your program by growing up your team and serving more patients. Next, please. This is also the question I asked for my mentor. The title of this talk He asked me these issues to stay humble. He told me this when I was in Japan. Stay humble, pick up young, motivated team members, and exert all your efforts. This is Professor Moriko Sahara. Next, please. This is just to encourage you again. Also, this is a dream, and this dream will come true, I think, within few months. I believe in you, Dr. Okello. Next, please. And this also for us all to stay united for Africa. As I told you before in the conference, Africa deserves the best, and we want to go forward because the African people suffers a lot and they need need the help. Okay, next, please. Thank you very much for this nice invitation.
All right, thank you very much. Over to Brian.
Yeah, thank you so much, Dr. Mohammed, for that wonderful talk. And at this juncture, I don't know if you have some questions in the chat. I see comments, some people are saying, thank you so much for the informative talk, excellent presentation.
But I'm so sorry. Are you hearing me, Dr. Okello?
Yes, we hear you. Go ahead.
Okay. I can go ahead. Okay. Okay, first of all, I would like to thank Professor Michael Okello for this nice invitation and this kind invitation to be with you in this society and in this Zoom meeting for your Society, the Endoscopic and Surgeons of Uganda. I'm Mohammed Sami consultant of hepatobiliary surgery and liver transplantation in the National Hepatology and Tropical Medicine Research Institute in Cairo and in the Cairo Academic Hospital. And also I have some training in pediatric liver transplantation in Japan. Professor Michael Okello was talking with me about how to start liver transplantation. So I will try to go quickly during this maybe 15 minutes to emphasize these issues. I will not talk about anything scientific. He already has a very marvelous illustrated talk about the basics of liver transplantation, but I'll try to go in the implementation procedures, how you can put your program on the right way. So first, I will share these lessons we have learned about for over 20 years. We started, the real start for transplantation in Egypt was in 2001. But first, I will go a step back and say that the first lesson we learned was when to start, because we have a very bad start, and this bad start costs us a lot. The first trial for living donor liver transplantation in Egypt is in 1991. Just very shortly after the living donor liver transplantation was started in 1989, maybe 2 years ahead, we tried the first trial here in Egypt. We have 4 cases were done in 2 different hospitals with the aid of 2 English teams from England. But unfortunately, the result was very unsuccessful. And the cost was that we have 10 years delay in this issue because the results was bad, and this cost us to wait for 10 years to start our program of living donor liver transplant. I would like to say that in Egypt, we don't have a cadaveric program until now. We have a cadaveric law, but we don't have a cadaveric program until now. It is not implemented until this moment. But the only way of transplantation here is the living donor. So we're just working in living donor liver transplantation only until this moment. The real start, I can say, or the restart for us was in 2001. In August 2001, one of the biggest private hospitals in Egypt starts the first living transplantation program with the aid of the Japanese team headed by Professor Tanaka. And shortly, maybe a few months, maybe in the beginning of the second year was 2002, a second program also started in one of the biggest private hospitals also in Egypt by the aid of Professor Olivier Boileau from France. So we have started by 2 different teams and 2 foreign teams, one from Japan and the other from France. By 2000, and they stayed maybe for 3 years. We have only these 2 private hospitals or these 2 private centers in Egypt. In 2005, we had the first living donor transplantation program in a governmental hospital. This was a teaching hospital. And meanwhile, between 2005 and 2006, we have three universities, three of the biggest universities in Egypt, also starts their program. So by 2006, we have 6 programs or 6 centers for liver transplantation. So we started in 2001, and maybe in 5 years, we have 6 centers working, 3 university centers. One is the teaching hospital, and the other 2 was a private hospital. So from the lesson 1, you have a bad start, okay, and this start costs you 10 years. I will go again back at the end of this session to emphasize what is the bad start, because I know that I intended to put it in the first slide. Some people could say that it's a pessimistic way to start, or it is a very depressing or frustrating part, but I will emphasize this at the end. So it is not a big deal to have a better start, but don't delay this, don't pay this cost. This is what I want. Lesson 2 is where to start. After when, it is where. So maybe you are unlucky in Uganda now because you have already established your center. But for anyone who is with us, who maybe in other country or something, that sharing our knowledge, I won't say that you have a private hospitals or governmental public hospitals. The private hospitals has some points that is more, or advantages that you will not find in the public hospital. It is easy to communicate with the shareholders because just you want them to persuade them with the idea, and it is always be beneficial for them, and it gets some money for them, so they can encourage and go with you in the way. Also, they have the financial support. They have no problem in the money. They can spend money. There is no complicated bureaucratic obstacles or administrative papers like the governmental hospitals, and also most of the private hospitals that can withstand the liver transplantation program should be very well equipped hospitals with no shortage in supplies or manpower or machines or something like this. Because liver transplantation needs somehow a very huge maybe machines, and as you know, Professor Okello, liver transplantation is an operation that is full of details. So these details you want to cover it. So you need machines, you need manpower, you need supplies, you need a lot of things, and this is not found at the private sector. We find also only in the very large foundations or the big hospitals. Other side, if you go to the governmental public hospital, as I always say, you will need 3 things: the administrative will, which I mean the political will, or the administration of the hospital. They are encouraging you to do this job, and you will also need a motivated team. Because the transplantation is as I told from maybe a few minutes, it's a very detailed operation. It has a lot of details, and it entails to exert a lot of efforts, and also the financial reward is not so big. So a lot of people don't like to go or participate in this program like this. So in governmental hospital, you have to choose this. And sorry for the. Can we get back? Sorry. Okay. And the last thing in the public hospital that you found your way to overcome the obstacles that we will see. Okay, we can go. This is a new photo, but from an old place. This is the first place who started living liver transplantation in Egypt, is a private hospital in 2001. But this photo, I will get back maybe in this slide, in next slides, I will emphasize them. So can go for the next slide. Okay. This slide is talking about the infrastructure. I will tell the Egyptian way. we have here a committee that is this committee is inside the Ministry of Health. It's called the Higher Committee for Organ Transplantation. This committee has put some restrictions and conditions for any place who want to take a license for transplantation. And this conditions is about 114 points concerning or dealing with the medical files, the ICU, intensive care, the operation rooms, equipments, machines, the radiology department, laboratory department, blood bank, endoscopy unit, sterilization unit, how you can get rid of the medical waste. Every single item in the hospital have some points, maybe 10 points, 15 points, 20 points. It depends on how this department is very valuable in the liver transplantation issue. And when you see that you want to make a program, you go to this committee, the Higher Committee of Organ Transplantation in the Ministry of Health, the Egyptian Ministry of Health, and you put there an application that you want them to come and check your hospital. And they come with this checklist, which is consisting, as I said, of 114 points. And you need to take 70% to be accepted. Less than 70%, you are failed, and you will need another visit and another evaluation. But if you get more than 70% in the evaluation, they get you the license to work. The license is for 1 year. And then if you did a number of cases, this number may be nowadays, what I know that you have to do at least 1 case per month, 12 cases per year. So if you did more than 12 cases per year, you will get your license renewed after 3 years. But if you do less than 12 cases, you get it year by year. Okay. So this point also for you, Dr. Okello, to know. So this is the point about the license. Okay. Lesson 3, who will start? This is also a very important point. Maybe you have discussed it with you before. As I said before, that we have started here with 2 foreign teams in 2 programs in 2 different private hospitals. One with the Japanese team was Professor Kyushi Tanaka from Kyoto University, and the other was the French one, Professor Olivier Boileau from Lyon University. And the 2 teams, the foreign teams, have incorporated with them 2 Egyptian teams, okay? And those 2 Egyptian teams went to Lyon and went to France and went to Japan to take their foreign training there for 6 months before the start of the program. So when the program started here, you have some people from Egyptian that are trained in these centers with the foreign team that comes. Maybe it resembles you, Dr. Okello, and your friends when you go to India. If you can start with the Indian team, so you will be the milestone, and the Indian team will come to you to help you. So this is the experienced team. Okay, next. This is a point also I maybe emphasized it with you before, that from day one, okay, from day one, you have to make a step up deal with this in the foreign team. Foreign teams in transplantation is very nice teams, and they help you in the first cases and this issue. But if you let everything not undetermined, most of these teams does not like to go away, because already they come and they spend with you some time, and for them they come on the flight on your expenses, and they stay in the hotel on your expenses, and they take some money when they come back. So you have promised if they start day one to put your independent plan, okay? And this will depend on your team motivation and skills, because the skills of the team, and this point I don't say about the surgical team only, but surgical team, nurses in the OR, nurses in the ICU, the intensive care doctors, the radiology specialists or consultants, the anesthesia team, maybe some involved the pathology team. All of this has to work in harmony, and all of this has to gain experience at the same time. So you will need a lot of people that are motivated, and depending on their skills, how they can make the switch, that they can go and take over from the foreign team. This depends from one team to other, but what I can say that from 20 to 30 cases, maybe more or less, but this is the average, about 30 cases. You will need a foreign team with you. As a step up, as I said to you, that you start with you doing all the operation, that the foreign team will come and do all the operation. Then after step by step, you can take some steps, and every step you have to take it for 4 or 5 cases until you master it, and then go to other step until at one day you will do the whole operation under their supervision. They will also be with you, but your team, the local team, will do all the operation, and then you at the time that you are independent team totally, you can say them thank you, and we will just invite you when we want. And I will tell you also in the next slides maybe some examples about this. So what my advice in this issue, that pick up your favorable experienced foreign team, whatever the team you want, focus on one team and only one team, and follow the way they are doing, and then start. Don't bother yourself which team I will start with, but get one team, whatever the team, and start with. After 5 cases, 10 cases, 20 cases, anything, you will get another school and another school, another school. But just focus on one school from the start and try to start, because this will hinder you from starting. No, I want you to start. Okay. Next, please. This slide may be somehow important also, because you have to persist and resist, as I say. Persist the bad result in the first few cases. For example, in one place I worked, in my place, our second case of liver transplantation has died in maybe 72 hours. So this was very frustrating, because our first case was very nice, and it goes out of the hospital very early, but second case unfortunately has problems. So don't make this bad results in the few cases, in the early cases, make you frustrating. This is complications. This will happen with you or without you, with a foreign team, with anybody. So just accept the complication and go forward. The other point, that persist in spite of the complication done by you in your first case. I remember also my personal experience. The first case I had done a total recipient hepatectomy by myself. I was very astonished from me and proud of myself, and I took some pictures inside the OR for the graft and for the operation, and I put these pictures immediately on the Facebook, and with thanking my team and thanking my people on this issue. But unfortunately, when we put the graft in this patient, the same patient, the graft didn't work well. She developed portal vein thrombosis on the table, and the artery, the hepatic artery, has done the thrombosis may repeated 4 times. So it was very bad. By the end of the operation, maybe on the second day, I think she developed DIC, and she stays with us maybe for a few days, and she died also. So you will find some complications that happens. So also persist. Don't bother yourself. Don't blame yourself for anything, because you are just have your learning curve. Also persist in spite of the obstacles put on your way by whatever person. As I told you before, you will find some people, maybe they are some colleagues, maybe some administration, some people from outside your hospital. They're just waiting for your failure at over the corner, okay, of the street. So don't put them in your mind. You have a plan, put your plan and go forward. But don't bother yourself who will say what. any word, because you will find a lot of rumors, a lot of sayings that will be said on you and on the patient, especially if there's some failure, the patient died or patient has complication or something like this, or patient go reoperation. You will find a lot of rumors. The one word, when it is said by many persons, it become a sentence, and the sentence become more sentences, and this is the point. So don't bother yourself with this. Also persist in spite of the deficiency of medical supply and manpower. This is also very important, because when you start your program, maybe you will find a lot of people interested, but after maybe a few cases, you will find a lot of people getting out of the program, because they see that this program will not add for them, maybe technically, they will not add for them financially, it takes a lot of time. They cannot do the effort of the operation for many hours and then go for follow up every day for the patient and know what is happening. So you will find some people, maybe your team at the first case or first few cases, when you find maybe about 20 persons, everybody want to come and see what is happening and participate in the start. But after a few cases, these 20 persons may be 5 or 4. So don't bother yourself also with this. This is ordinary. And also the medical supply, this depends on the importation. We use a lot of things that is imported from outside our countries. So and sometimes like HTK, for example, this is not we don't do it, so you get it from outside, and sometimes it has a shortage or something like that. So you will find a lot of maybe obstacles in the medical supply to have a continuous medical supply. So put also a plan for this medical supply, how to make a store for you, away from anything, away from everything. This store, you have your supply away from anybody, that you can use it when you want. And you have to resist also two things: the power and the authority of the older generation who don't want you to grow up. This is very important, because this happens everywhere, in Europe and in Africa and in Asia and everywhere. When you start something new, you will find a lot of people that are older than you. They see that this is a very young surgeon, why he took this opportunity, why I didn't took it, and they try to put some obstacles for you by their authorities and their power, okay, either in the administrative field or in the medical field. So try to resist them as much as you can, and don't hear from them. You as I told you, put a plan and go forward. Also, another thing you have to resist is the arrogance and selfishness after the success of the early cases, because when you have by God wills, you start your program and you have your first cases, and you have success in maybe in the first or 5 or 4 cases. So you will see yourself, feel of pride of yourself, and no one can talk with you. You are moved or transferred to another level inside your country. All the people know that Professor Okello is the best surgeon. He is the liver transplant surgeon, the only one, and this issue. So try to resist also this humanitarian instincts. Okay, so this is very important also. Okay, next. Next, please. Okay. This is something about the start. This is my Japanese team. I stayed with them for 1 year, Professor Kasara and all the team. I will tell you something that this was told me by Professor Kasara himself, that he was a member in the Kyoto University in a very huge and maybe the first team in Japan for liver transplantation, and this team was working very, very well, and he's one of the cornerstones of this team. By 2005, his mentor, Professor Tanaka, told him, you have to go to Tokyo and start a pediatric program there. So Professor Kasara was very he didn't like this decision, but his mentor told him, you have to go there to this place and make a pediatric program, initiate a pediatric program there. He told me that when he came in 2005 to the hostel, he just found himself alone and with 2 nurses only. He didn't find anyone. and he start to prepare the infrastructure for the transplantation in few months by himself only, and 2 nurses only. Then he has get some colleagues from Kyoto University, 2 colleagues from Kyoto University, and they become 3, and they started to make a liver transplantation. From 2005 in the National Center for Child Health and Development, the NCCTHD, and he says that in the first 3 years, he just did 3 cases per year for successive 3 years. But nowadays, after persistence and after resistance, as I told from Sun, and after exerting all the effort, nowadays he has done more than 800 cases. And mostly the center where I was taking my training there, his center, is doing 70% of the pediatric liver transplantation in Japan, 70 to 80 cases per year. Japan has some 5 centers for pediatric liver transplantation, but this center do 70% of the work. And he's the only center that can deal with the acute liver failure patient, the metabolic diseases, and the tumors, liver tumors, like hepatoblastoma. All these cases are transferred from all over Japan to this center, because the only center that has the equipment to deal with these issues and has a program and has a protocol for everything like this. And nowadays it becomes one of the biggest centers in Japan and one of the largest in the world in concerning pediatric liver transplant. Okay, so this is also something to know that you have to start, even if you start alone, but by time and effort you will get bigger. Okay, next please. Lesson 6 for me was that you have to start by any way, but your goal is not to start. Your goal is to maintain a program. This is the point. And I shared with you now that maybe in Egypt, since 2001, we have done more than 7,500 liver transplantation now. And we have more than 22 centers maybe now in Egypt. Many centers of them, or not many centers, but I have some centers that does not working at all. Maybe in the last 2 or 3 years, they didn't do a single case. And we have some centers that do a very limited number, from 5 to 10 cases per year. And also you have some centers doing from 10 to 20 cases per year. So what I want to say that plenty of centers is not an advantage for you, but you have to focus maybe on 1 or 2 centers. If this is enough for your country, focus on them and try to grow up them as much as you can. And I will maybe say an example now, like in Saudi Arabia, they have 3 centers, but they do maybe about 500 cases per year in the 3 centers only. Maybe it is the same in Egypt. We have 22 centers and we do 500 cases per year. Okay, but with some differences that in Saudi Arabia they had a cadaveric program, so most of cases are cadaveric. But we here in Egypt, all the cases are living donors, so it is more difficult here. Okay, so we have 2 governmental hospitals now. One is University Hospital, and another one is public hospital. They are doing now both of them collectively do maybe from 150 maybe to 200 cases per year. This is maybe the most working places in Egypt now. Even more than the private hospitals, but as I told you, we have plenty of centers, and every center maybe do a limited number of cases because a lot of issues, but at the end of the day, we collectively in Egypt do perform from 400 to 500 cases per year. Okay, this is maybe so if you have 1 center. And also I give you the same example. Saudi Arabia, they have 3 centers. One of them is King Faisal. They got the foreign Professor Broring from Germany, and he now is performing mostly 300 cases per year. Almost is doing a liver transplantation every day or the other day, something every other day or every day, something like this. He do a lot of cases. So what I want to say that if you have only one center, you can make it a very high volume center. If you have many centers, you can also make it, the patient will be distributed on them. But the point or the advantage of having one center for the start, this is very important, that this center can do a lot of numbers. So next, please. Okay, this is an example for my center, one of the two centers I work in. We started in 2018, doing 7 cases only in the first year, and then 2019 we have done 22 cases, rising, and then 2020, this is the Corona year, the COVID year. We succeeded to maintain maybe the number, and this was very, very successful for us. In 2001, this is the year I returned back from Japan, and we started to make our pediatric program, because I started the pediatric program there. So we have done 37 cases in this year, 2001. We started 3 cases pediatric, and then second year, 2022, we have done 61 cases with 50 cases of adult and 11 cases of pediatric. And last year we have done 65 cases, 61 cases in adult group and 4 cases only in pediatric group. So I started the pediatric program here, and this with the assistance of my colleague and my professors also in the team after my return from Japan. And until now in this center I have done 18 cases until now in these 3 years maybe. So this is what I can say. This is a growing program. Okay, this is a growing program. Every year you will get more numbers and more patients than the year before. This is very important. Okay, please, next one. Okay, this slide I put it for what we can say the doctor-patient relationship. In the transplantation, the patient will see it every day. Maybe you see it every day for a month. And in the preparation, you can see this patient maybe every week or every other day. And after the operation, you will see this patient twice a week. At first, maybe first month, then every week, then every 2 weeks, then every month. And this patient you will see it all over our life. So you have to make a very great bond with this patient, because this patient you will see it lifelong. Okay, this is different from any other surgeries that you make the patient and after 1 week it's okay, remove the stitches, can go home safely and just email me on the Christmas time. But in the liver transplant, this is very different, because this patient is living with you, or you as a doctor living with him, because every detail in his life will be shared with you. Okay, so I just want to highlight some points in this issue, that solving the patient problems means more patients will come. There are 2 or maybe 3, can I say 3 main problems for the patient regarding the living donor liver transplant. The first one is the financial issue. And this financial issue, I will now say the Egyptian Bardo experience in it. Before 2019, there was what we can say that the medical insurance, okay, or the governmental authority share with the 1/3 of the cost of the operation, and the patient has to go to some charity society. Also, they were 2 societies, charity societies. They share also 1/3 of the other, second third of the operation cost, and the patient has to pay for the other third, the last third of the operation cost. So the operation was divided on 3. One of them is 1/3 was paid by the government, and the other one by charity societies or association. The third one was by the patient. From 2019 till now, due to some presidential initiative from the president, nowadays the medical insurance and government totally sponsor the operation, totally sponsor the costs for any Egyptian person who want to go for liver transplant, organ transplantation, or some oncosurgeries, maybe a lot of things like this. But I just say here about the organ transplant. Anyone who want to liver or kidney transplantation is done for free on the expenses of the Egyptian government. Okay, this is from 2019. So any Egyptian who want to make a transplantation, he didn't pay anything concerning the operation itself. Okay, which I mean from the admission to discharge. And also post-operatively, if this patient is also an Egyptian, he can get his medication monthly from the medical insurance for free also, okay, on the expenses of the government. So the intraoperative or mean the perioperative period, the patient doing the operation and then doing the operation and then put in the hospital maybe for 3 weeks or 4 weeks, and the donor and recipient, all these expenses, the operation and all medications and labs are done, radiology, everything on the expenses of the government. And post-operatively, all the expenses regarding the medications is also covered by the government. Okay, this is the financial issues. The only next slide, please. I'll see. The only point that is held by the patient or paid by the patient is the preparation. The preparation period before the operation. This is only on the patient because no one can have this cost. We, as a team, okay, by some personal communications or contacts, make some deal for the patient with some radiology centers and some laboratories to make a discount. Maybe it reaches 50 to 60% for our patient from our center. Okay, this is exclusively for our center. Just depending on some contact that we will send you the patient, please make him a good discount, and I will send you more patient. And this helped the patient so much in the preparation issues. Okay. Also, there is some charity societies also in Egypt, maybe one or two. They try to help us in the preparation because also the preparation is somehow costly. So the patient who cannot afford the preparation cost, we send him to some charity societies. These charity societies make some search for this search on these patients' social level and economic level, and they get verify his condition that he already needs some help, and they try to help him with maybe 70% of the preparation cost. They send him to some labs. They have some contacts with them, contracts with them, and they take special prices from them, and also send them to some radiology centers also. So by our personal contact and by the charity societies, we can help many people in this step of preparation. So in what I want to say here, conclude that the operation itself is for any Egyptian, the preparation, the operation itself is on the expenses of the government from 2019 due to a presidential initiative. And the post-operative medication also is for free from also the governmental expenses. And the preparation, this is only the only part that the patient can cost. So we try to help him as much as we can. Okay, solving this issue make some people get trust in you, and also more people will come because you are put the patient in your hand and try to solve his problems. Okay. And also I want to say here something that these charity societies also support some non-Egyptian people. Okay, in the preparation issues, I mean. Some people, non-Egyptians, okay, from Arab world or from Africa, they can come for these societies and they can help them with some money or some issues, but not all the preparation, but they can put some money for help, okay, even for non-Egyptian people. And I think this is maybe not found anywhere. I don't know in India if there's something like this, but here in Egypt, I think this is exclusively for some charities. Societies here help these non-Egyptian people, okay, our patients, I mean. The second point for the logistics, this also you have to consider what I just try to try to transfer my experience, okay. Please advise your patient if he's from outside or from a far area from the center of the transplant, advise him to rent a place or an apartment or a house, anything near the hospital, not more than 30 minutes from the hospital. This is for the first 3 months post-operative, because he will come every now and then for the hospital. You have patient with bile leak, you have patient with any problem, surgical or medical, some people with rejection, some people or anything. So you'll find patient complaining of a lot of things. So he will not stay for the hospital for his life, but he can go home and come every 3 days, come every 4 days, come every week, and you can assess him. So you need the patient to be very near from you in the first 3 months. And also because if it happens any complication or something accidentally or suddenly have any problem like this, he can come easily, okay? Because we also, some patient, if the patient is living 400 kilometers from the hospital and he had developed hematemesis, or he had developed any problem like this, or have any thrombosis in the artery or the vein or something, when he come to your hospital, the time you lost maybe 4 or 5 hours, this is the saving time for the patient. So advise your patient, if he's from any far area, not from the center of the city, any far area, to rent a place beside the hospital or near the hospital, maybe not more than 30 minutes from the hospital. That this will help him so much in the first 3 months. After 3 months, he can go back to his country, home country or home city, and he can deal with you, no problem, because you will come maybe once a month or something for the follow-up. But the first 3 months are very, very valuable, very, very important. So keep your patient beside you, okay? This is also a piece of advice. Okay, next, please. Okay, also for the logistics, okay, you will find some problems concerning the acute liver failure patient. I know that this is not suitable for a beginning, but you'll find this patient. When you put the sign that you start transplantation, everybody will send you the cases because you are the only center in the country. So you will find some people with pulmonary hepatitis or acute liver failure or hepatocellular carcinoma. These patients wants to make a fast track. You have to plan or design a fast track preparation items for them, okay? Specialized fast track preparation items program, because this patient will not with any time is against him. So he will not stay until you make all your preparation and make the thrombophilia gene and this sophisticated radiology. You have to make everything so fast. So please, from now, start to implement a program how you can deal with these emergency cases, because the pulmonary hepatitis or the acute liver failure, you have to transplant it maybe in a few days. And also hepatocellular carcinoma, we try to finish it as much as we can, not in days, but at least it took a few weeks, maybe 3 or 4 weeks maximum. You have to transplant this patient. So put them in a specialized way, even if you make some contacts with the Ministry of Health to exempt them from some unnecessary steps in the preparation. Okay, focus on what is very important for you, the things that you will need it, very important, and try to omit or cancel temporarily all the things that are unnecessary, because you have to make this preparation very, very rapid. I will tell you something about Japan. When I was there, they just in Japan, they prepare the donor, any donor, for any patient. Okay, so even if it's emergency or not, even cold patient, any donor is prepared in the same day. Okay, I will repeat it again. Any donor is prepared in one day.